Hello, and welcome to this American Thoracic Society webinar entitled A Burning Question, Identifying and Understanding Burn Pit Syndrome. We have experts here who will discuss the strategies and challenges for diagnosing and treating burn pit-associated lung disease in veterans. Thank you to the American Thoracic Society for hosting this webinar. The mission of the American Thoracic Society, or ATS, is to accelerate global innovation in the advancement of respiratory health through multidisciplinary collaboration, education, and advocacy. Founded in 1905, the ATS is the world's leading medical society dedicated to accelerating the advancement of global respiratory health through multidisciplinary collaboration, education, and advocacy. Core activities of the Society's more than 16,000 members are focused on leading scientific discoveries, advancing professional development, impacting global health, and transforming patient care. If you are joining us today and are not already a member, we warmly welcome you to visit www.thoracic.org to learn more about membership and its benefits. Join us. I would like to take this opportunity to thank the ATS professional staff for making today's event happen and all of our collective work at ATS possible. Special thanks to Miriam Rodriguez, Managing Director of the Assembly, Research and Awards Program, Erica Forrence, Assembly Programs Coordinator, and Javier Guzman, Associate Director of Grants and Awards. I'm Dr. Jessica Kastner, Professor and Director of Nursing at the University at Albany and President of Kastner Incorporated. I serve as the current chair of the Terrorism and Inhalation Disasters section of the ATS. As a board-certified emergency nurse and nurse scientist, I've led policy-informing research focusing on environmental drivers of health emergencies and emergency care. In the Terrorism and Inhalation Disasters section, we are a multidisciplinary group who share a common interest in inhalation disaster preparedness, response, and research. The major goals of this section are the advancement of current research efforts to improve the understanding of the pathophysiology and management of inhalation injuries, severe outbreaks of infectious disease, and their impact on respiratory and critical care management, and to maximize disaster preparedness. We are housed within the Assembly on Environmental, Occupational, and Population Health, or EOPH. EOPH is concerned with lung disease related to air pollution, occupational exposures, tobacco smoke, allergens, bioaerosols, and other environmental agents, along with genetic susceptibility to lung disease related to the environment. This includes epidemiology, inhalation toxicology, occupational environmental medicine, and industrial hygiene. We welcome your engagement and involvement in the TID section and EOPH Assembly. It is now my distinct pleasure to introduce our TID co-chair, Dr. George Anisi. Dr. Anisi is Director, Medical Care Bioresponse Program, and Medical Director, Special Pathogen Treatment Unit, Hospital of the University of Pennsylvania, as well as Assistant Professor of Medicine in Pulmonary Allergy and Critical Care at the Hospital of the University of Pennsylvania. Dr. Anisi, over to you.
Thanks so much, Jessica, for the introduction. So again, my name is George Anisi. I'm a medical intensivist and clinical epidemiology and health services researcher at Penn, and I focus my work on capacity strain and hospital preparedness. So very excited to work under Jessica as co-chair of the TID section and to help with this program near and dear to my heart. So I have the pleasure now of just briefly introducing our two moderators, and then we'll get to the meat of the session. So Dr. Ranu Siroli is an assistant professor of medicine in the Division of Allergy, Pulmonary, and Critical Care at the University of Alabama at Birmingham. Dr. Siroli's basic science laboratory studies the chronic effects of environmental intoxicant exposures on the lungs, including using mouse models to study vesicant exposure and constrictive bronchiolitis. And then Dr. Bradley Richmond is an assistant professor of medicine in the Division of Allergy, Pulmonary, and Critical Care at Vanderbilt University in Nashville. He's a pulmonologist and physician scientist with a basic and translational research program that focuses on the pathogenesis of small airways disease in both COPD and post-deployment respiratory syndrome. He's the PI of a VA-funded military exposure innovation center that's focused on small airways disease in veterans, and he's the site leader of the VA's post-deployment cardiopulmonary evaluation network. I'll be back at the end to facilitate questions, but for now, I'll turn over to Dr. Siroli to introduce our speakers. Thank you.
Thank you, Dr. Nasi, for your kind introduction, and Dr. Kastner, TID OPH members and ATS for providing us the platform to discuss this issue. Today, we will be discussing burn pit exposure and related respiratory complications, as well as new preclinical animal models that aim to understand chronic respiratory disease related to burn pit exposure. Over the past few decades, millions of veterans who served overseas have been exposed to burn pits, which have been a serious health threat. These pits were used to burn waste materials before leaving the deployment site. Unfortunately, no EPA regulations were followed, and often jet fuel was used to incinerate the garbage, causing the generation of more than usual amount of PM2.5. Burn pit produce toxic fumes that can cause significant harm. These burn pits were used to burn various materials such as plastics, computers, batteries, munition, medical waste, and even human waste. The plumes of smoke of these burn pit expose military personnel to PM2.5, heavy metals, and various kinds of polyaromatic hydrocarbons, resulting in severe respiratory problems and other serious health conditions who served after 2007. For the first time in 2011, a report in New England Journal of Medicine showed that the young soldiers who served or were serving and exposed to burn pits had indolent presence of constrictive bronchiolitis. And after the plethora of evidence and cases, the PACT Act was passed last year, and that acknowledged that the burn pit exposure led to chronic respiratory disease and several other serious health conditions among our veterans. Due to the presence of wide range of toxicants in the burn pit fumes, it is challenging to develop an ideal preclinical model to understand the mechanism of deployment-related diseases and to test potential therapeutic targets. Today in this webinar, we will be discussing the strategies and challenging in diagnosing and treating these patients. We will also have presentations on newly developed animal models that mirror the pathophysiology of in the lungs related to burn pit exposures. So now, without further delay, I will now turn over to Dr. Richmond to introduce our first speaker. Dr. Richmond.
Thanks, Dr. Shrolia. Good afternoon, everyone. Great to see how much excitement there is about this webinar. I think this is really going to be a lot of fun. It's my privilege to introduce our first speaker today, Dr. Neas Sotolongo. Dr. Sotolongo is an assistant professor of medicine at Rutgers Medical School and the Robert Wood Johnson School of Medicine, where she practices pulmonary and critical care as well as sleep medicine. And she's also a staff pulmonologist at the East Orange, New Jersey VA. She co-directs the Airborne Hazards and Burn Pit Centers of Excellence at the War-Related Illness and Injury Study Center there at the East Orange VA. And she's an executive committee member for the ATS section on terrorism and inhalation disorders, and has also served as a consultant for Environmental and Occupational Health Science Institute, where she was instrumental in the evaluation of first responders to World Trade Center. I've known Dr. Sotolongo for several years now through our work at the VA's post-deployment cardiopulmonary evaluation, which she also co-directs. Dr. Sotolongo is a clinician, and that was purposeful. I think it's really important that we get both the clinical and pathologic aspects of this disease before we start to consider the ways that we can best model it in preclinical models. So, Dr. Sotolongo, thank you for your time, and turn things over to you.
Okay, thank you very much. I'm going to try to share my screen, and hopefully it goes well. And let's see, I think this is right. Can you see my screen?
Yes.
Yes. Okay.
Yes.
And is it in screen mode or is it in presentation mode?
So it is.
It's in with notes?
Yeah, it has the slide deck on the side. So
okay.
Yeah,
all right, let me try that. If not, how's that? Did
Perfect.
that work?
Perfect.
Yeah.
Okay. Ready to roll. Okay. Usually I have to put in this as a disclaimer: no disclosures to report, and the contents of this presentation do not necessarily represent the views of the U.S. Department of Veterans Affairs or the United States government. Okay. Let me just start by saying good afternoon, good morning, or even good evening, depending on where you are in the world. And thank you for having me and listening to this presentation. Oops, sorry. So I want to sort of get a general timeline, if you will. How did we get here? And I apologize if people know the story already, but I want to make sure that we're all starting from the same point. So it really started when sort of the first round of Operation Iraqi Freedom and Operation Enduring Freedom, the first sort of second, the first wave of the second war in the Iraq area, the Southwest Asia area, came back, and a few surveys were done, and what they found was about 33% of the veterans or military personnel that came back reported a definite or probable exposure to environmental hazards. And then another survey, and these were primarily from military personnel who were at Joint Base Balad, a quarter of them noted persistent major health concerns due to deployment exposures. And over the following, let's say 10 years from that time, so that started around 2005 or so, from then the next decade, clinicians were noting and publishing a wide range of disorders, diseases that they were noting in veterans who were reporting exposures, which range from rhinitis, sinusitis, to rapidly progressing idiopathic pulmonary fibrosis, and a whole host of things in between within the respiratory system. Now, certainly the first thing that people thought about, especially when that survey came in from Joint Base Balad, was that it was the burn pits. They didn't know what was being burned. All sorts of stuff were being burned. They were using solvents and jet fuel to burn it. So they said that was the cause of it. And that was really the sole cause of it. And there was a study done by, started from the military of the Millennium Cohort, and they looked at veterans who were in close proximity to the burn pits and compared them to veterans or military personnel who were not as close. I think it was a 3-mile radius, people who were within the 3-mile radius compared to those who were outside of that 3-mile radius. And they didn't see any specific increase in those military personnel who were within that radius when compared to those who were outside of that radius. So there was a rethinking that it may not necessarily be just the burn pits. This was not meant to say that burn pits were safe and there were no diseases. It was just that it may not be all burn pits. And what people, as myself and others were looking at, was that there were more than just burn pits regarding inhalational irritants. Some of them was the sand and dust, the very fine particles that were being inhaled by the military personnel. There were oil well fires. There is no EPA in Southwest Asia, so particulate matter from just general pollution were part of that. And so the next theory, if you will, their speculation was that it was not burn pits per se, but the increased inhalation of particulate matter, specifically small particulate matter, or PM2.5, and the number stands for the diameter in microns of the particulate. So small ones, not only 2.5, but it can be like 10 PM10 or something along those lines. But particulate matters that pass by the natural defense mechanism of our respiratory system. So the mucous membranes in our nose, or the hairs in our nose that would usually catch the particles, our ability to cough these particles out, those smaller particles bypass that and can be, or thought to maybe, embed themselves into the lower airways and therefore causing some chronic inflammation. To add to that, if you will, or to bolster that theory, this is evidence from Dr. Garshik and his group in Boston. They looked at they measured some of the particulate matter concentrations in many of the areas of the theater, so in Iraq, Kuwait, Afghanistan, and as you can see here, they are way higher in what was considered to be acceptable thresholds in the US. The straight line, the solid line, is the 1-year sort of acceptable threshold, and the dashed line is the 24-hour acceptable threshold for PM2.5 particulate matter in the atmosphere. And as you can say, they are way over that in many, many of those cases. And then on the right of the screen, there's a question of, well, is it just the airborne hazards exposure? And there's a question whether that is, it's just that one thing, in that there are veterans who come back who've had the exposures, and once they're away of the exposures, they generally don't have symptoms, but there is a significant percentage that do. So the question is there a subset of military personnel who may have increased vulnerability or increased susceptibility to having long-term respiratory symptoms? And in that slide on, or that figure on the right, there are just several things that military personnel go through in addition to the airborne hazards exposure that could lead to general overall changes in the body sort of makeup. So exposure to not only sort of oil well fire smoke and jet fuel smoke, there's tobacco smoke. It's known that military personnel, there is an increase in smoking. Individual susceptibility factors. Maybe someone had childhood asthma that, even though may resolve, may have been triggered again because of the inhalation and the exposure to the particulate matter. Stress and violence. These are men and women who are in fear of their life every single day without break. And so that can add to the stressors in one's body and one's respiratory health. And then exercise, ventilation. If you're exercising in poor air quality, you're taking in larger doses of these particulate matter, and you're breathing faster, you're breathing deeper, and therefore getting higher doses of it. And then just overall general military living conditions. Okay, so into that came the seminal article by Dr. Miller and his group in Vanderbilt. That was in the New England Journal, noting that some of the veterans that he had seen and had biopsies had some constrictive bronchiolitis. So I don't know whether or not you all know the details of it, but I thought I'd just go through it really quickly right now. So in general, there were 80 soldiers who were referred for unexplained dyspnea, and the main thing was that they were not able to do their 2-mile run, past their 2-mile run that they did before they were deployed. They weren't able to do it after they were deployed. So they were referred to see Dr. Miller. The majority were served or were deployed to Iraq only. There were some that were deployed to both Iraq and Afghanistan, and one person was just Afghanistan. They had a fairly extensive workup, and there was no definitive diagnosis of what could be causing that problem. So of the 80, 49 underwent biopsies, and 38 received a diagnosis of constrictive bronchiolitis, and their definition was greater than 20% increase in the airway wall thickness versus controls. And then the other 11 received other diagnoses, other respiratory issues that may be causing that. So the take-home points that I think from the New England Journal article is that all lung biopsies, all of those 49, were in fact abnormal, even though that the majority of them were diagnosed as constrictive bronchiolitis. Some of the exposures that they had gone through were Mosul sulfur mine fires, military burn pits, sand and dust storms. These were sort of common, but they weren't essential. So there were veterans who had just been deployed, may not have been in a sand and dust storm, but may have just been exposed to sand and dust and had symptoms. And then the findings in the routine exams or the routine workup were not specific. So into that, there was a lot of controversy when that came out. There was a question from some pathologists whether or not the criteria for constrictive bronchiolitis was what we would normally use. And then there was a tension between service members and clinicians. Service members were saying, that's what I have. That's why I'm not breathing well. I need a biopsy to prove that. And clinicians saying, I don't really feel comfortable having people referring people for lung biopsies and without any obvious clinical signs or imaging abnormalities. Into that, there was a 2020 NASM report, the National Academy of Science, Engineering, and Medicine, which sort of serves as the VA's review board. highlighted that controversy and recommended that the VA convene a multidisciplinary panel. And in 2022, the Airborne Hazards Burn Pit Center of Excellence led that effort. So we used a modified Delphi approach. So it was a combination of large meetings and small meetings and creating final statements and looking at the final statements and voting on the final statements, and finally creating a manuscript and a toolkit. The manuscript came out in chest, our rivals for ATS, but and the consensus statement was looked at and created. I want to show that, like on the right side, you can see we had a good multidisciplinary group. We had pulmonologists, we had environmental and occupational medicine, and even more importantly, or I think to round out the group, we had pathologists and radiologists. And we had a nice mixture of VA personnel, DOD, academia, and even some folks from other federal agencies. And what came of it was that to simply call it constrictive bronchiolitis wasn't really helpful. I think what the pathologists were saying to us is like, sure, you can give me a slide and say constrictive bronchiolitis, yes or no, but that leaves out a whole host of abnormalities that we are not addressing, and abnormalities that can hit multiple components of the lung and multiple respiratory, from the upper airways to the lower airways. And so the consensus statement said not to simply call it constrictive bronchiolitis, but to maybe develop a term, deployment-related respiratory disease, which encompasses all the respiratory abnormalities that could be associated with exposures during deployment, and that it might take a comprehensive approach to get to a diagnosis. And so within our post-deployment cardiopulmonary evaluation network, we do have a very multidisciplinary and extensive clinical evaluation. There's cardiopulmonary, there's the health and exposure questionnaires. We have high resolution CT imaging, both with inspiratory and expiratory scans, and also extrapulmonary evaluations like upper airways, ENTs, CTs of the sinuses, and echo. This is not to say that everyone has to go through this, but these are things that we do and find we can get diagnoses, not 100%, don't want to say that, but we can at least narrow down some of the issues that may be happening. We know that everyone can't read a whole manuscript or don't have time. I shouldn't say can't read, don't have time to read a manuscript, especially have a busy clinical practice. So we sort of distilled what we found or what the consensus statement was into a toolkit, which are not necessarily clinical guidelines. They're more in terms of helping you make decisions, clinical decisions. You can either sort of rock it old school with a foldable print copy. There are some QR codes that you can scan if you wanted a little bit more information, or you can go to the website in which you can, which is a little bit more interactive if you had issues with regards to questions about, well, what respiratory questions should I be asking? What environmental exposure questions should I be asking? So you can click on these and get some specific questions that may help you. And okay. So in summary, I know the title is burn pit syndrome, but I really want people to think that it's more than just burn pits. It is a whole host of airborne hazard respiratory inhalation or irritants that a veteran or military person went through, and can be causing some of these problems or all of these problems. It often requires a detailed exposure history because there could be synergy or sort of an additive effect to all the exposures that they had, and can often also require a stepwise comprehensive multidisciplinary approach to diagnosing the tests beyond PFTs. And again, we feel that constrictive bronchiolitis is too narrow a diagnosis to adequately describe the range of respiratory abnormalities, and we should think more of deployment related. I know there are problems with that term as well, but I think we need to broaden what's going on and what abnormalities occur related to exposures, the airborne hazards exposures. And lastly, it takes a village. These are the folks that I work with, all of whom were incredibly smart and dedicated within the Airborne Hazards and Burn Pit Center of Excellence. And I hope I made it within my 15 minutes. I'm done. And I will stop sharing.
Thanks, Dr. Sotolongo. That was really excellent. I think this sort of highlighted and framed the problem of how complex this disorder is, complex in terms of its exposures and complex in terms of phenotypes as well. It's also my privilege to introduce our next speaker, Dr. Sergey Gutor. Dr. Gutor is a research assistant professor here in the Division of Allergy, Pulmonary, and Critical Care Medicine at Vanderbilt, where working with his mentor, Dr. Vasily Polosukhin, he's led work studying the pathology and molecular features of deployment-related respiratory disease, to borrow Dr. Sotolongo's term, using those biopsy specimens from Dr. Miller's cohort and then others who have undergone biopsy here. Dr. Gutor has also developed a really interesting mouse model that recapitulates many of the features of this syndrome. Hopefully he's going to tell that today. He asked that I make his introduction as short as possible to give him as much time as possible. So I'll do that. I did want to interject and say there's already some great questions in the chat. I believe we're going to wait until all three presentations have completed and then have an interactive time for questions, both from the chat and from the audience. Correct me if I'm wrong in that, but I think that was the plan for today. So Dr. Gutor, turning it over to you.
Thank you very much for a kind introduction, and it's very short. You did great on that, but I do intend to use this extra minute. Let me share my screen. I think you should see it by now. Okay,
Yep, we can see it.
And let me do this because I want to show a few things. So thank you everyone who joined, and thanks to Drs. Surley and Sotolongo. I can skip a long introduction, but I do want to emphasize the general scheme of the problem that we started to work on back then, that basically well, mentally, physically fit military personnel got deployment, got exposed to various of airborne hazards, and end up with the inability to pass this 2-mile test that they were able to do just before the deployment. But many of this part of the group were diagnosed with asthma, COPD, some acute lung infection, and so on. However, approximately 30% remain undiagnosed, and that's exactly the cohort that I'm going to talk about, and that's we worked on. So, when we started the histopathology of the lung, and we indeed see the constrictive bronchiolitis like pathology in airway, and we see this subepithelium thickening and smooth muscle layer thickening. So basically there's a complex airway wall remodeling that feed the constrictive bronchiolitis as a diagnosis. But at the same time, in the arteries that adjust to these airways, there's a significant vessel wall remodeling as well, that's sort of not exactly typical, but might be relevant to some vascular pathology in the lung as well. So with this, we can call the problems that these people have as a bronchiovascular bundle centric, but at the same time, in a parenchymal tissue in alveolar wall, we do see the decrease in capillary density, the collagen and elastin deposition in alveolar wall, as well as we see some parenchyma pleura pathology, the thickening of the pleura, some inflammation, and neoangiogenesis. And with this, we with the I believe it was 18 morphometric parameters of a distal lung, we did the um, non-supervised clustering and got these two completely distinguished clusters, and that was a overall idea that showed that this is a distinct from normal pathological distal lung condition. And we proposed as a post-deployment respiratory syndrome as a descriptor for this combination of a history of a deployment in the Southwest Asia and Afghanistan, inhalation exposures during the deployment, chronic respiratory symptoms that persist, and the broad distal lung pathology that basically affect all distal lung compartments. And with this, we started to work on the mouse model to reproduce that pathological condition. And basically, we picked the sulfur dioxide as an exposure agent because it was common air pollutant, and it was known cause of the constrictive bronchiolitis. That was an initial diagnosis in King's 2011 paper. And that was the most frequent inhalation exposure in the soldiers with the PDRS. And with the dosage, it was relatively easy to pick because it was reported. But the rest of the conditions, we went through the model optimization, and we pick the airway as the main area of focus of the pathological for the model optimization. And eventually we end up with the specific model that for 4 hours a day, we treat mice for 10 days throughout the 2 weeks period of time, and then we give them approximately 4 weeks of a rest period. During that, they develop the rest of pathological conditions. Acute stuff goes away, and the only persisted pathological changes are remain. And we do see an airway wall thickening and increased collagen deposition that accounts approximately 50% of increase, and the chronic inflammation in the lung that persists even 1 month after the last exposure. And with that, to our surprise, we saw the pulmonary vascular pathology as well. Despite it was not the main goal for optimization for that pathology, we still recapitulate that with our conditions. And the pulmonary vascular, like arteries that were just to small airways, they have the tunica media thickening as well. And in a human pathology, it's evidence of a potential pulmonary hypertension. But in a mouse, there's another feature that's more common. It's a muscularization of distal vasculature, and it's what we analyzed as well. And there's indeed a shift in proportion of the muscularized distal vasculature that's seen in these mice. So, we sort of decide to dive deep into this vascular pathology part, and because the sulfur dioxide is a sort of well-known source of superoxide and some other oxidative species, so we try to evaluate the number in the endothelial cells, and we see indeed the increase both in the lung tissue and endothelial cells, specifically the accumulation of the superoxide. And the working theory is that this caused the mitochondrial oxidative stress damage, and we indeed saw even 1 month after the last exposure, we were able to see the accumulation of isolevoglandins that are product of oxidation of lipids, increase in the acetylated SO2 and decrease in the SORT that's sort of a part of the mitochondrial redox mechanism. And basically with that, more or less showing the idea that endothelial damage and oxidative stress might be part of the reason that can be involved in the pathological conditions. And there are a few treatments of that are available and that you try to evaluate. And interestingly, the isolevoglandin scavenger 2 hobo was able to basically decrease the effect of sulfur dioxide on the muscularization and tunica media thickness. So vascular part was recapitulated, but not airway part. And the same with the SOR3 were expressed in mice. So basically, we tried to tweak both of these redox elements in the mitochondrial, and we do see that it might be indeed part of the vascular pathology in this model. And then we started to think what exactly happens with these mice in terms of physiology. And we did some flex event measurements, and there were no difference. Even this is actually mice that are 6 months after the last exposure, so we let them age a bit, and even with this, there's no difference, and it's pretty close what we see in the actual veterans as well. They don't have a robust abnormalities in PFT as well, but at the same time, these mice do perform worse in terms of exercise ability. So we did incremental exercise tests, and they perform significantly less than untreated mice. At the same time, we checked, and they do have the physiological signs of the pulmonary hypertension as well. So the right ventricle systolic pressure goes up and the Fulton index goes up. So it's more or less the signs of the potential pulmonary hypertension that are associated with the chronic lung disease. And with this, we sort of went back to the human tissue and reanalyzed the histopathology, and we of course see the pulmonary arteries adjusted to smaller airways had the abnormalities. We compared that to idiopathic pulmonary arterial hypertension that were and these specimens were obtained during the lung transplantation, so it's very severe disease. But even that, there's a difference from the control, and slightly less than in the pulmonary hypertension. And the same abnormalities were seen in the more smaller vessels that intraacinar arteries and both veins have the significant pathological changes basically in all 3 layers of a vessel. So overall, this significant pathological changes in the vasculature might be a sign of the pulmonary hypertension. So we did the same unsupervised clustering analysis and the principal component analysis. And as you can see with this, it's sort of grouped into the 3 distinguished clusters. And there is some veterans that end up having some overlap with the non-disease control, and there's a relatively significant overlap with the pulmonary arterial hypertension patients. So with that, you can think about it that there's probably this subcategories of the level of the pathological changes in the vasculature that you could call like mild, moderate, and severe. But at the same time, there's a pretty significant overlap with the actual very severe pulmonary arterial hypertension people that got their lung transplanted because of the disease that they have. So with this, I want to thank you for a lot of people that helped throughout this work. Obviously, my mentor, Vasily Polasukin, who was a PI on this grant, and thank everyone for the attention.
Thank you, Sergey, for such an interesting and knowledgeable presentation. And your model showing that inhalation injuries are not just injuring lungs, but also have involvement of cardiovascular system. That shows that the systemic inflammation is very much involved in these respiratory diseases. And with that, we will move to our next speaker, Dr. Matthew Gore, who is assistant professor at Ohio State University. And he is involved in researching how environmental hazards can cause systemic changes, especially in cardiovascular systems. Dr. Gore recently received his R01 grant funding to study communication between fibroblast and immune cells in heart interacting in response to pulmonary hypertension. Dr. Gore is also associated with War-Related Illness and Injury Study Center for Cardiopulmonary Studies on PM2.5 exposure models with Dr. Wold team. Today, Dr. Gore will be discussing his preclinical model of burn pit exposure using a combination of short-term stress and chronic exposure to PM2.5. And for this model, they used a stress model called social defeat concept. Social defeat concept is a stress model where mice were repeatedly housed with aggressor mice, and then these mice were exposed to PM2.5. So without further ado, I would like to welcome Dr. Gore and to tell us about this preclinical animal model. Dr. Gore.
Thank you very much. I'm really excited to be here, and thank you to the other two speakers. This is I'm seeing already a lot of sort of similar thoughts with what's happening with the pathology, as well as just how different one particulate matter exposure can be for one person compared to another. So I hope to harp on that a little bit more. But yeah, I'm really excited to share some of this work that we've been doing at OSU. This is part of Dr. Lauren Wold's group, and we recently published just really a beginning of what we've been getting into, as already mentioned, and looking at how particulate matter exposure and stress can interact and change cardiopulmonary function. So obviously a lot of this was already said, so I don't have to say too much, but there are a lot of military members, first responders, and other occupations that are exposed to both air pollution as well as stress. There's a lot of psychological distress. I don't need to argue that too much in a lot of these occupations. So our concern was, how is this co-exposure working to change cardiac or pulmonary function? And is there an exacerbation, or do they have shared mechanisms? I'm proposing inflammation of those. You'll see we're still working on ironing all that out. As mentioned, I've always liked this picture. It's been around on the EPA's website for a very long time. You probably see it in all of your presentations, but PM2.5 is particulate matter in the air that's smaller than 2.5 microns. So that includes really every fraction that's below that. You can see how small it is. And it seems like as our technology for detection of particulate matter gets better and better, that we're realizing it's the smaller and smaller fraction that's causing these health defects. So I have a feeling the field's going to keep changing to even looking at even smaller fractions of the smallest fraction of PM2.5 as well. But that's been our focus, this is what we're able to measure. And our main big question is, what are the long-term health impacts of a co-exposure to PM2.5 and stress? We're interested not only now starting to look at the acute exposure to PM2.5, what happens when, in our case, a mouse first breathes in an excess amount of PM, but also what happens when that happens over long term. What are we seeing happen to cardiac and pulmonary function? This is our exposure system. If it looks homemade, that's because it is. But the The air is brought in from outside of Columbus, Ohio, actually right out my window here, and it's concentrated in a system here, and we control for humidity and temperature, and it's fed in through a Cyrec chamber into the mice here. And each airflow for each mouse, they have an independent flow of air, and they're exposed to PM at a higher concentration than what's outside. So it's usually about 5 to 10 times, and I'll discuss that in a moment. So this is based on collision. So a lot of air is brought in, several of the particles collide onto an apparatus, and then that's how it's concentrated and sent into the mice. So these mice are experiencing a real-time dose of particulate matter. If there's more outside, then they get more, and if there's less outside, then they get less. And I'll show the numbers for that in a moment. So we've been exposing them for 6 hours a day, 5 days a week, for a total of 3 weeks. And a lot of the data we followed up, within 48 hours of the last exposure, but we've been playing with that as well. As our last speaker, waited for some time to see what developed. We're working with that as well, and I'll share some of that data. We also have a stress model where, as was already mentioned, we put our mice with an aggressor mice. They usually fight for a little bit. We make sure there's some social avoidance based on observing them for submissive behavior, and they're put in there for the last 10 days of PM 2.5 exposure, and then they're put back into their own cages for the rest of the night. So we do this for a period of time in the afternoon, and then they're put back into the cages for the evening, and then they have their PM exposure during the day. So what's in our PM? We've done an elemental analysis, which is a clip of that is shown here. Some of that's been published. If you're interested in specific elements, we do find a lot of things that you would expect, a lot of metals. And the concentration, at least for this first set of data, is about 22 micrograms per cubic meter. That's the 24-hour average. So this is not, it's not a very high dose, but it is higher than what you'd expect the certain guidelines to have. And it's also higher. It's sort of like if you're living in a big city is what I like to say. And this paper was already brought up, but places in the Middle Eastern area from this paper showing 35 to 100 micrograms per cubic meter. So we think we're actually a little less in this first study than what someone might have been exposed in those regions. So looking at another paper mentioned here, we've sort of just looking at only PM 2.5 levels. We sort of made the guess that this is something like a deployment length of 1.4 years. So I'm happy to share that math with you at some point. We did flex event, which was mentioned by the last speaker, and we do find a slight increase in lung resistance under a methacholine challenge, so not at baseline, as well as elastance. And this is where our story really starts to emerge, is that stress and PM seem to really have the same effect. When there's stress alone, which is shown in red, we see the same changes as if with PM, and when they're together, it's not like there's an additive effect. So that was very interesting to us to see this play out, and we're starting to see the variations in this story based on our exposure. We did this is working with Dr. Gowdy's lab with her grad student Hannah Levins. Looked at the BAL fluid, and we did find neutrophilia in these after exposure, as well as some evidence of pulmonary damage. Although the histology of the lungs looks, we're not really able to find much damage, especially not what was shown by our last speaker in terms of vascular damage or airway issues. But we do see that there is some minor lung pathology. There is an insult that's occurring. We're interested really in how the heart responds to particulate matter. We've published over 10 years ago now that a long-term exposure to similar amounts of PM over a 9-month period actually shows reduction in systolic function and cardiac function. However, with 3 weeks, as we sort of expected, we don't see a change in any of the systolic measures, which are shown here. Stress also doesn't seem to play a role in that, at least for the amount of time. We looked at diastolic measures. This is via echocardiography, and we also found no changes. But interestingly, we did invasive pressure volume loops in the left ventricle, and we found a reduction in a key measure here, which is contractility. And again, we see that stress and PM are causing very similar changes. Interestingly, we're also finding, when looking at the right ventricle via echocardiography, a slight reduction in I'm sorry, the axes are all wrong here. They say E to A, but the stroke volume is reduced, as well as some other measures that, and the cardiac output measured through the pulmonary artery was found to be reduced with PM stress or PM and stress together. We looked at the capillary density in both the left ventricle and the right ventricle, and found that in the right ventricle we did see an increase. There's a small number here, but it looks like in all three of our insults, but we didn't see any changes with the LV capillary density. So this is suggesting that there is some response to the right ventricle towards this, whatever changes the PM and stress are causing. And we've begun to start to look at inflammatory markers. And interestingly, we ran a large panel in the serum of these mice right after exposure, and found that a lot of the inflammatory markers were reduced. And those are the shown. CCL2 was reduced, IL-6, TNF, alpha, missed an alpha there, are reduced with PM or with stress and PM. So, but not with stress. So we're really interested in trying to figure out the question, well, if these are reduced, then where are they going? Perhaps is maybe a good question, but we've begun to look at these markers in tissue as well. This again is in plasma. So looking at inflammatory other inflammatory markers within the heart, we're finding that there's also a reduction in several of these, although there's really nothing major that's happening. We do see eventually these changes in heart dysfunction, but it doesn't seem that inflammation is really causing that. So my first thought was maybe that we're getting some inflammation in the beginning. So we started to do an experiment where we're exposing for 1 day or 3 days, and then we also do our 3-week controller stress, and we are finding, again, just some decreases in gene expression in the heart of these mice. Well, the other thing that we're playing with is the PM concentration. I was just sent this week. This is the PM that we've given mice over the last 5 years, and so if there's a gap, it's because we're in between studies, or in the case of April 2020, it was COVID shut us down for a few months. But you see there's a very large variation in the PM that these mice can receive. And sometimes it's below 50, usually in the winter. You can see January here is below January. And then, so we have sort of a seasonal changes that we're viewing. So this is kind of putting together 2 different exposures, looking at spring exposure in red, so you can see the PM levels with each day. This is the peak for that day. And then a summer exposure where you have a lot more PM. And this wasn't last summer, but last summer we because of wildfires, we had an enormous amount of PM that was coming through. But so we're looking at how we're able to sort of naturally vary the PM dose with this, and then follow through with, with sort of the cardiac and pulmonary phenotype. So these data shown here are looking at the heart again, and we're looking at what happens 6 weeks post-exposure. So just like our last speaker, we waited for a period of time, 6 weeks, and we found that there's sort of different changes that are occurring. Again, we do see a minor reduction in cardiac output, but again, this is a small number here. But so we're trying to figure out what exactly is preserved after that amount of time. And then this slide is showing what if we do the stress before PM. So our thought with this was to have a stress, before you're encountering larger numbers of amounts of PM in the air could change the way that that your lungs are responding. We did find that didn't have the same change in cardiac function, although again, we're getting a lot of a smaller number with our EES. This was reduced when stress was during, but it's not reduced when stress is occurring before PM. Interestingly, though, I put the stress on the right two sides here. It seems that stress is the one that's causing the reduction more than PM. So we're just beginning to explore this. We have several cohorts now where we've exposed the mice to different levels of PM, and we're sort of putting all the physiology together to try to have a sort of computational model is at what dose of PM are we starting to see long-term effects to the heart and lungs. So I'll just conclude the short-term co-exposure to PM and stress. It does seem to alter pulmonary and cardiac function. And this is something we can see in a lot of occupational settings, but it probably causes notable effects on health, though we're really interested in these sort of follow-up studies on what's happening long-term. And so then the timing of the stress is also very interesting to us, and actually what stress that they're encountering as well. So we're working with some other constrained stress models and looking into how that might change the cardiopulmonary response. With that, I just like to thank everyone. This is our beautiful building at Ohio State, and this is all done in Lauren Wold's lab, and we've had a lot of help from our group here. But thank you.
Thank you so much. Wonderful talk. So we are coming up against the hour, so we're gonna take some questions, and we have the ability to spill over, but because people may need to drop off at the hour, I'll preemptively say an amazing thank you to our speakers, to the moderators, and to ATS staff, and then to the audience for coming. So I'm going to ask a couple questions that have been in the chat, and then we'll open it up to others. And again, we can spill over, but obviously everyone is welcome to go about their day as they need to. So first question for Dr. Sotolongo, actually two related questions that came up earlier. The first was from Dr. Rubenstein about whether we see similar manifestations of burn pit syndrome or kind of deployment-related lung disease in local populations that live near where these military bases are. And then a related question, I think, from Dr. Teodorescu about whether there's any adaptive mechanisms in local populations that we've identified, if I'm interpreting that question correctly. So Dr. Sotolongo, any comments on those questions?
Yes, that has been asked several times, and people have tried to assess whether or not in local populations was there something similar. It's been very difficult trying to do science in a war zone. So being able to get people who have whether they have something similar that they said, well, before the war I was fine, but after the war I'm having trouble. People move. So the short answer is it's been very difficult to try to find a cohort that says that there has been something similar. It's also hard to figure out whether or not there is adaptive mechanisms for people who've always lived there compared to folks who are used to maybe cleaner air because there's an EPA in here or something similar in maybe Europe. So again, the short answer is not that I'm aware of. No, there's no information per se about whether or not the native population have different adaptive or have sort of that similar sense of not having feeling short of breath or having dyspnea.
Thank you, appreciate it. Next, I have one question submitted for Dr. Gutor. In the work you presented, you had selected sulfur dioxide as kind of your model toxin. One question is how we would, obviously PM tends to have many components to it. And the question is, how would we go about potentially testing synergistic effects between multiple toxins versus a single one isolated in a more kind of in vitro setting? So any comments about how one might approach looking at kind of concomitant exposures and synergistic effects?
I would say it's a pretty hard task all these combinatory effects, because based on literature available, the dosage, let's say, of sulfur dioxide that normally does not have any effects, in combination with something else, amplified and has a robust phenotype, sometimes even worse that we've seen. So basically, for the modeling purposes, you don't want that complication, right? As far as you not study these combinatory effects. But overall, in the actual field, obviously, people got exposed to multiple exposures at the same time, and they do have the implication, right? It's close to we think about medication, right? If person taking 2, it's more or less manageable. If it's 5, 10 at a time, it's became hard, right? So the same thing with the toxins and exposure, and affects them on the long.
Thank you. And then a question for Dr. Gore. This was a question about kind of individual susceptibility differences, and in particular, whether there is whether variability in, if I'm interpreting this question correctly, how much PM is actually, how much deposition there is, and variability in that between individuals, and whether how much that may account for different perceived susceptibility later on in a disease process.
Yeah, I think that's an incredibly important question. I think there's been, throughout the last several decades, like an attempt to sort of have PM monitors on individuals as a way to monitor that. However, I think that's where the strength of a mouse model comes in, is we're able to make sure that they're getting the sort of same dose for each one. But I'm really interested to see if, just based on the question, there's a question about native populations, but if even mice are able to sort of adapt to this, and you know, if you have a second exposure, if we don't see it as you know, a series of effects and things, but that's where I think the strength of a mouse model can come in and help us.
Thank you, appreciate it. We have a couple questions, I think, that are heading back to Dr. Sotolongo in a more clinical context. Questions about early diagnosis based on either pulmonary function tests or biomarkers, and then whether there is, from a pulmonary hypertension standpoint, baseline versus inducible pulmonary hypertension that you see in these patients.
Oh, that's a lot. Yeah, I think we're in the early stages. We're just beginning to, I think, get a handle on defining the problem. So kind of early diagnosis, I don't know that we're there yet. We're still we're just in the diagnosis part of it. We would love to start doing early diagnosis, but I don't know that we are clear as to who, because there's such individual susceptibility, who will, you know, have a decrease and maybe stay that way and therefore adapt to the new sort of lung function, who will continue to maybe have deterioration in their lung function or their functioning. It may be cardiac, it may be pulmonary. So all those things are still yet to be defined. Unfortunately for the people who are suffering, that's probably not very reassuring. But yeah, we, as you can see by this group here, both who spoke and who are in the audience, they're dedicated folks who are trying to find answers to this and trying to put something together that will help not only the veterans who suffered this, but you know, populations who are not veterans, who are maybe in that same situation, inhaling stuff they shouldn't be inhaling under stressful situations. So that may have not have been a very great answer, but that's the best I have. We're still working and trying to define the problem. If anyone else has anything, any thoughts? Yeah, I don't know.
I appreciate that. Thank you. And there's clearly interest in other comments about moving even further towards therapeutic approach and treatments, and we welcome that at future discussions. Maybe we'll take an opportunity now to open it up for any other questions or comments. maybe folks can raise a hand and I'll go in order. If there's anyone else who wants to chime in. Dr. Porteous, Philadelphia VA. Go ahead.
Hi, great talk. Thanks for organizing this. What role do we think, if any, kind of telomere length plays in pollution-mediated damage in this population, right? I think you have a mouse model there, so in theory, and at Penn, there's kind of interest in developing a fibrotic mouse model with, so there's some collaboration potential. But on a side, right, all of these veterans are young patients, right? And so, you know, how does that factor in, given at their young age? That may not be a factor, but certainly is a factor in ILD mediated damage.
I'll start off the not being as a clinician, we certainly know that stress, even stress at a young age, can cause issues with how we adapt, how that affects our life cycle, if you will. So certainly, even though these veterans are young, they've gone through a, for lack of a better word, a bolus of stress that most of us would never go through, and how that affects their ability to heal and their ability to fight off these types of insults, I think, are affected. And I also think one of the things that we see in many of these veterans who are reporting this, they also have PTSD. And unfortunately, we as clinicians think, well, I can't find anything wrong in any of your tests, and you have PTSD, therefore it must be in your head. And to a certain extent, that is true. I think one's mental state affects one's ability to heal and adapt. And so, yeah, when you have veterans who have PTSD and lung disease, I think the two of those things really do affect one's telomeres and may shorten it. But this is from a clinician outside, have not looked at their DNA, but let's say I would not be surprised. But I'll let folks who actually do the hard science chime in.
Yeah, I think that's a great thought. I haven't looked at that at all. So I think, yeah, again, that's an advantage of a mouse model. You know, if we're able to look at this, we're looking at older mice now and exposures, so that, you know, that could also have a different. We're seeing different effects there. So I think that's a great thought.
Yeah, and in our case, we have not done it either. I will not be surprised there's some relation to that, but that's not much that we can do right now. But with established model, we have at least a tool to test multiple things, including that. So yeah, thanks.
I see a hand up from, and I apologize if I mispronounced it, Dr. Darkween.
Yes, Dr. Darkin, thank you.
Darkin, thank you.
Yes, I wanted to make a follow-up comment on for Dr. Sotolongo on the potential large variability between subjects, human subjects, now not animal models, in the retention of particles in the upper airway that may prevent a big reaction or a disease progression. Do you have data on images like MR images or CT images of the upper airway of the soldiers that developed the syndrome? Because if you have that, in silico modeling could show or predict at least how much particles would be retained in the upper airway, and could give you an indication, because it can vary with this particle size from like 10% retained to 90%. And it may be that the people that develop tends more to be have their upper airway geometry such that they don't retain that much particles there that can then be cleared by mucociliary clearance.
I have not looked at sort of that in depth about the sinuses. As part of our workup in the cohort of veterans that we do see, our group, the Post-Deployment Cardiopulmonary Evaluation Network, of which many of the directors are online, hello all, we try to get the imaging of the sinuses. So maybe there can be some collaboration in which there can be a view of the sinuses and maybe some sort of measurement about retention of particles. We do see that veterans do have a degree of sinusitis in there, but yeah, we haven't looked specifically to see whether or not we can see particles or a way to assess whether there's particle retention. That's a great idea.
And also, if I may, it's also during deployment, they're not just breathing at rest, they're exercising. And so they switch a lot of their breathing through the oral pathway, which is much less effective at filtering particles. And so that's another aspect too, that may be the cause.
Absolutely.
Compared to the population in the area that spend more time resting than running on a field with 80 pounds on their back. So, yeah.
Actually, to follow that thought, I saw an article where people study where the particles can go in terms of how small air weight will land depend on the physical exercises. So it's actually increase the distance that the particle can reach in the lung, all the way up to the distal lung, even though normally it will be stopped somewhere in the bronchial level.
Very interesting. Thank you. I see a hand from Dr. Teodorescu.
Hi, thank you very much for this interesting seminar. I have a question about the other larger particles. Seems to me that much of the focus, particularly in animal models, rests on smaller particles. However, many of my patients in the VA clinic come with kind of airway symptoms, including upper airway and also asthma-like phenotypes. And I believe in that those initial studies in the millennium cohort, about 40% had airway reactivity. So what do we know about these allergens, biological allergens that tend to be trapped more in the central airways? What do we know about their content in the Middle East? Were samples, is there any modeling done with them currently in this deployment lung disease? And what do you guys know? Or should there be?
I think you're absolutely right. And the first sort of wave of veterans that came through, the majority, or a good portion, I won't say majority, the good portion of them were diagnosed with asthma. And I think one of the things that happened was because there was a diagnosis, there isn't as much emphasis on trying to understand the role, because to a certain extent, from a clinician standpoint, we know the issue, and we know, yes, and that they veterans who were deployed came back with respiratory things like asthma, sinusitis, rhinitis, are more likely to have sinusitis, asthma, and rhinitis. That's why there was a presumptive for that. There hasn't been, I won't say a lot of work, but I think the emphasis was more on the veterans that we couldn't, or the service members we couldn't quite pinpoint the diagnosis. So yes, there probably should be more work on the upper, on those who are suffering from the upper airway issues. But I think the general sense, unfairly, is that, well, we have the answer for that. Yeah, we do blame the exposures on that, and therefore what we want to find out is what is the pathophysiology of the more smaller airways.
And or further, there may be some sort of synergy slash interaction. I mean, none of these particles in other situations that people have modeled act in isolation.
Absolutely.
So, and frankly, in my clinical experience, that's the most prevalent feature, phenotype in the deployment-related lung disease. So yeah, I agree that there should be some more understanding, because these are individuals who at least initially did not, prior to they were screened, albeit not tested, but they were screened out for asthma. And who knows what sort of asthma phenotype they evolve into. with the deployment.
If I may,
Yes, go ahead, Dr. Thur, go ahead.
yeah, if I may have a little follow-up here, but yes, it is known that asthma, the huge part of the people who have the exertional dyspnea, and sort of in our work, they got excluded as a exactly because of the reasons that Dr. Satalonga just mentioned. But there are few studies related to asthma itself and the vocal cord dysfunction, and actually plenty of these airborne hazards, right, that sort of may lead to this distal lung pathology that we've seen, for example. It can initiate or cause the exacerbation in asthma related as well. So yeah, but I think overall majority of people with exertional dyspnea that can be diagnosed, most of them got diagnosed of asthma or hyperactivity.
Do we know anything about the composition of the Middle East environment in terms of allergens? Like, I know that in Arizona, for example, in different seasons, kind of a desert type of environment, spring, it's a lot of, orchard kind of citrus orchards and, so, but what do we know about Middle East allergen burden?
I'm not sure we have an immediate answer to that, but it's a good question. In order that they come up, Dr. Porteous, did you have a follow-up?
Yeah, just we talked a lot about kind of airway manifestations, and we've kind of all talked about the different phenotypes, but twofold is, I mean, I've seen such a variety, a 36-year-old with really bad hypersensitivity pneumonitis on a cryobiopsy, carcinoid tumors in patients. What are we, as clinicians who are seeing these patients, kind of what's the pathway that we can kind of continue to all collaborate so we can kind of, identify this somewhat rare outcome and a rare kind of subtype of this deployment-related disease? Like, can we send you like sample, right? Like, how are we doing this? Thinking kind of on a larger scale. Certainly, we can get people to register as being affected, but what can we do to help in this collaboration?
Well, I do know within the VA, we have created sort of as I mentioned, this post-deployment cardiopulmonary evaluation network. And we are trying to be, right now we have 6 sites, of which Dr. Richmond is the director of one of them, and I see Dr. Silpa Kraft in there as well. We are trying to be more responsive and try to figure out a mechanism by which we can reach out to those who are inside the VA and outside the VA in trying to get this information, because we know that not all veterans are seen at the VA. So we want to be able to work with those who are outside of the VA, try to get information out, maybe try to figure out a way we can move to be more collaborative. But as of yet, we have not come up with a mechanism. Maybe watch this space and we'll figure something out. But yeah, absolutely. I think the more we can share ideas and understanding of the various people that we see, the better, the quicker, and hopefully we can come up with treatments and for these veterans who are suffering. Bradley, did you?
Working on the pulmonary.
Sorry. No,
the pulmonary. Just as a follow-up, the Pulmonary Fibrosis Foundation, PFF, where a subset of us are working on creating almost kind of, where can patients go regionally for interstitial lung manifestations? That obviously is not specific to just burn pit exposures or deployment-related diseases, but that's also something that another group of people that we can kind of bring into this fold.
Sure.
Maybe a final comment from Dr. Richmond, and then I think we will close out. Go ahead.
Yeah, thank you. I guess just to maybe bring this around full circle and really to dovetail with Dr. Porteous's question, I'd ask Dr. Gutwar and Dr. Gore, based on what you've learned from these models, what types of treatments do you think we should be looking at in preclinical models or in vitro models?
Yeah, I was really interested to see Dr. Gutwar show some pulmonary hypertension changes there as well, and I think that's not. I don't know if, and I'm not a clinician, so I don't know if that's something that we've seen begin to develop or something we might expect to develop and as a secondary, factor here. But yeah, this has been a really great discussion. Just I have a lot of great ideas now coming in. I'm thinking about allergens again, and yeah, thank you.
So commenting on that and combined with a few chat messages, we actually do have a very small cohort of people that we did the right heart catheterization, and we indeed saw some mild pulmonary hypertension in them, even if it's short, but it's still there. So in terms of treatment, there might be, again, because of from the pathological perspective, we see this muscular layer thickening. So maybe it's pretty close to I know it's tonus based in pulmonary arterial hypertension, but there's might be some overlap in terms of treatment that might be effective on this cohort as well, as soon as you do have proven elevated numbers in the pressures on the right heart. So, but in terms of overall, I think as Dr. Setalonga mentioned before, we're probably a little bit early in the stage to have any robust answer to that can be tested right away. But at least we do have some tools available, including both models that were mentioned today, to test some.
All right, so I think I'm gonna, we're almost 90 minutes of fantastic discussion and presentations. I think we'll end here. We'll say thank you to the speakers, thank you to the moderators, our ATS staff, Jessica Castor, my partner in crime, and really thanks to the audience and a really fantastic discussion, robust questions and discussion. So thank you all. Stay tuned. Come visit us at ATS in San Diego for our annual meeting. And look out for further announcements for TID business. Hope everyone has a great day. Thank you.